from Harvard, MGH. He is currently having technical difficulties, but we'll try to jump in shortly. He's been trying to get on and may be able to get on in a couple minutes. But we're going to continue to proceed given the schedule. The disclosures are here just for the complete transparency of the speakers. And the next slide. Here's the agenda again. It'll be really moderated or presented, I should say, by Matt Goodwin. And then Joe and I will chime in, and then hopefully we'll have questions. And like Lauren said, if questions come up, please put them in the Q&A, and we may be able to answer them during the talk. If not, we'll try to get them to the end as long as we're not going too long, but it would be nice if it's interactive. So without further ado, Dr. Goodwin's going to present the first case out of 2.
Perfect. Thanks, Dr. Shuba. Thanks, obviously, to the SRS and everyone for being here for this webinar. We'll jump right in here. So case 1 is a 55-year-old gentleman who comes in really with no past medical history, no significant history, other than he has some neck pain. He's got some change in his voice, maybe some swallowing changes, but nothing that significant there. Educated man, works as a pharmacist. And on exam, he's intact throughout. He, maybe has a Hoffman's, but otherwise, he's fine. He comes in with this MRI. So pretty impressive looking. You can see on the 3 views, you can get a real sense of the extent of this lesion. So you see on the sagittal, the extent that it goes back into the canal. Also appreciate on the axial. And then you also see on the axial that this thing seems to go quite far anterior and lateral, and also seems to encase the vertebral artery on that left side. We had a CT as well. Oops, I'm a little trouble. Had a CT as well. I'm not giving you the benefit of scrolling it, but it shows that there's a lot of bony destruction at the level of C2 around this lesion. And he's had no real other workup at this point. And so the first question that we'll do with the audience participation is shown here. So the question is, what's the next step for this gentleman? So your choices are up there. Yeah, he can have palliative care only, radiation treatment only. He can have staging plus a biopsy. He can have a stat biopsy now. And then after that, you have your surgical options. So you can get a posterior decompression with or without instrumentation. You can get an anterior surgery only, or a staged front-back surgery, either piecemeal or en bloc. And so we'll give you a minute to think about that and vote there. So it looks like most of us have voted. It looks like there's maybe one person that wants to move forward at surgery at this point. But I think the majority of folks want to do some combination of staging and or biopsy. So we have about a fifth of you saying go ahead and get the biopsy now, and the rest saying let's stage the patient. Let's go ahead and go to the next question. We'll take the same patient and we'll just change it up slightly. So in that case, most of us are doing some sort of workup, some sort of staging and or biopsy. Same patient, same history, and now we'll just change it and say the patient comes in with a week of symptoms. So now they say for 1 week, they've had changes in their leg strength. So maybe they're 3 out of 5 in some places on exam. Their grip's getting worse. Their balance been off for a week. And they're really having trouble standing or walking at this point. Is it different yesterday than today? Hard to say, but certainly they say over the last week, things have really declined. So that'll be the condition now, and we'll give you the same answer choices. So it looks like that changed things up a little bit for us. So we have one person saying do radiation now. We have still about half the people saying staging or biopsy at this point, but now some people have moved to say decompression. Some people moved to say go ahead and do the stage procedure, front and back, or it looks like we have some saying even do it piecemeal at this point. So we'll change this one more time. We still have 50% saying at this point they're staging, so some answers have changed. We'll take the same patient and we'll just tweak it a little bit more. So now we'll say the patient comes in and they've had loss of bowel bladder really over the last day. They said they were walking 2 or 3 days ago, and now they're ones to twos in their lower extremities, and really in the last 6 hours you've seen them get significantly worse. So there's this progressive paralysis over the last 6 hours or so. Everything else is the same, just a little more severe symptoms here, and we'll let you choose this again. So interesting results. So we changed it a little bit. We've now made the patient getting progressively paralyzed over the last 6 hours or so, or day, and we have 20% that are saying staging or biopsy, and the rest have chosen a surgical option, and the surgical options are really all over the map. So 50% of folks look like they're saying to do the en bloc procedure, and then the rest are kind of all over the map, 5 to 10% in each of the other surgical options. And so I think this is interesting to go through this workup, because this is something we talk about a lot, and I know many of you talk about a lot, and that is when are symptoms severe enough that you're going to skip getting the tissue biopsy, that you're going to skip doing the staging part of the workup. And it's something that seems to come up at every meeting, and some people are very hard and fast about getting tissue, and the reality is when you get a patient that's getting paralyzed, things sometimes change a little bit. Dan, I don't know if you want to weigh in a little bit on that series of questions, and I think I know some of your thoughts about how you handle that, but I'd love to hear you talk a little more about it.
Yeah, so thank you, Matt. On behalf of Joe, who can't make it and is texting us, those are the dings you hear, saying he's trying to still make it. This is kind of the way we set this up is what we often present. So what we get in these talks and these lectures that we give is we always talk about all these different ways to evaluate patients with tumors, and we're going to get to some of that, some of the high points of that shortly. But really, this is what it comes down to, right? This is what it comes down to on a day-to-day basis. You have a patient who comes in who maybe is not presenting with any overt progressive neurological decline, but they have a tumor and we don't know what it is. And so as we're going to see, that may push us more to a full workup, right? So we're going to be getting a staging to see if it's a metastatic lesion, or if we can guess where it's from, if it is metastatic. For example, if the patient has a colon lesion or a renal mass, something like that, that may say, oh, this is likely to be a metastatic lesion. And if needed, maybe a biopsy can be done there more easily. And then if that is not clear, if there are no other lesions, that may suggest that this is a primary tumor. And in that case, once again, that may push for biopsy. As we get to more aggressive presentations, whether it be mechanical instability or neurological decline, we're going to start becoming more aggressive with just taking care of the patient clinically. And that might mean stabilizing or decompressing them. And so as you can see, the way that Dr. Goodwin really put this out there was someone who was pretty benign clinical presentation without a workup versus someone coming in very, very affected. And obviously the audience responded in the way that I think most of us would. Now, just a little wrinkle to kind of bring up some issues is that what is urgent and what is not urgent is often what's brought up in these meetings or with colleagues of mine saying, well, what is urgent? Patient does have a have an increased reflex in their leg. Is that a neurological decline? In my experience, that might not be enough to avoid getting a biopsy and a clinical workup. On the other hand, people say, I heard biopsy is so important, and the patient at least, is anti-gravity in their legs, or maybe has only been really, really weak for a day. And so we're going to keep waiting. And in those cases, my own experience is that I would not wait for those. Now, maybe we don't have to completely resect the tumor. There are ways that we can maybe get an open biopsy and think about it if we want to try to consider that. On the other hand, if we can totally work up the patient, this is something I want to bring up before, if it's early on, we had a question, staging or stat biopsy, and some of those kind of are together. I think sometimes it would be a nice answer to have C and D together, right? And so if the person is completely stable and working at his job like this guy was, then staging and biopsy when they can do it the next few days, even though it looks bad. If the person's a little bit weaker, then you're stat biopsying, but you're also staging them, right? Because staging is easy. Just get a CT scan and then do the biopsy and tell the patient that we may take you urgently, but we're trying to see if we can minimize the urgency by trying to figure out some more information. And so one way to do that is to constantly communicate with the patient, saying, hey, if you're doing poorly, we're going to be aggressive in our surgery. But if you're doing well, we're going to keep waiting until we have those results. Because, for example, if this is a lymphoma, it can be radiated and it'll melt away. And if it's something that's a sarcoma, it may have to be have a more complicated workup. So I think what I wanted to say really was that Matt really put this out there. Now the data, usually what we do in lectures and meetings and courses, we start with all the research done, and then we give cases. And this is a really good way to do it that Dr. Goodwin's done, because it is what we live. And now you're sitting there forced to think about it. And if you think you're on the right track, for most of us, how we think, now you can pepper it with some information that Matt's going to show.
That's a great summary as to what we're working with. And as Dr. Schuba already said here, the issue is that there's a different workup for different pathology, as a lot of us know. So, what you don't want to do is, if this is a metastatic case, you don't want to sit around and wait and the patient gets worse and worse when you could have just gone and decompressed it. If it's a lymphoma, like you said, it might need radiation instead. And certainly if it's a chordoma, you need to be thinking about an en bloc resection and getting margins and not just diving right into the tumor. So I think in general, you're thinking about staging and biopsy, and again, that was a great summary from Dr. Schuba. Many times these go together. Usually you're getting the staging and you're working on getting the biopsy at the same time, and then you're thinking about your operative plan. And so involved in the spine tumor workup, obviously the good history and physical, I say obviously, but I know many times a lot of us don't do a great job of that. But a lot of these lesions, there's elements of the history that matter a great deal. So I know we had a coccidiomycosis case when I was with Dr. Schuba, who is a very odd looking lesion, looked like it could be a tumor, but you talk to the patient and he'll tell you that he was spending time in a warehouse in Arizona where they warned him of the fungus, and sure enough, that's what it was. So I think we can oftentimes remember to do a little bit better job of that than we often do. Certainly getting a CT, the chest, abdomen, pelvis, getting SPEP and UPEP are things I think most of us get. I think MRI of the entire spine is something we sometimes forget, but probably should get. And then I've also put in here plain films and the CT. I think a CT is important. Helps you see the what you're working with in terms of bone and whether there's any bony destruction. And I think the plain films help because for many reasons. I think one of the reasons is if there's any element of reconstruction that you're doing in the operating room, you might need some upright films to compare to. But also when you get in the operating room, oftentimes you'll be taking images in the operating room, and it sometimes helps to have seen a plain film beforehand because I know there's many cases where surgeons have a more difficult time than we'd like to admit reading the plain film we get in the operating room.
Yeah, if I could just make a comment. So one comment, and then there's a question from the panel that I think is a good time. The question that the panelists suggested was briefly describe what UPEP and SPEP are for an international audience. Those are the urine electrophoresis and serum electrophoresis. So that's when you send studies for myeloma or plasmacytoma. So there's usually a urine looking for those bench-Jones proteins, and then same with the serums to see if that, hey, you get this big spike in your IgG or what have you, and that's helpful in diagnosis. The other thing is people, this wasn't asked, but this is a question that often comes up about staging. Another form of staging is a PET scan. People talk about PET scan or CT scan, and I'll just tell you that it's probably more of a factor of who you are than what's better. In other words, a PET scan is usually ordered by medical oncologists when they continue to follow patients with cancer to see what the stage is and how they're responding. Are their lesions getting big, or are the lesions getting smaller? Are they becoming metastatic where they weren't metastatic before? It is often really considered a screening test, right? So they're looking at the whole body and seeing everything shows up. First, from an oncologist, it's about, is it present and is it coming back, or is it getting worse? But from surgeons, we're more anatomically based. So we like to see anatomic studies. So a CT chest and pelvis not only does the job of looking for lesions, but it also actually shows us the relationship of the rib to the lung and to the spine and the viscera. So when we're looking at a scan, we're actually saying, oh, this is helpful, in addition to the dedicated spine CT and dedicated spine MRI, that you actually have those as well. So people sometimes ask that. It doesn't really matter, but obviously surgeons usually and anatomists usually will order that, while the more screened the medical people will order the PET.
And then, from there, obviously the biopsy is something that everyone has on their mind when they see a lesion like this. So that's obviously part of your workup here. And then I think something that's become increasingly important is who your team is. I think as we continue in spine tumor care, we'll see more and more how important this is. I know certainly the institutions I've been, and certainly when I was with Dr. Schuba, it's a fantastic resource to have a multidisciplinary team, just because things are changing so quickly, both in chemotherapy and immunotherapy and radiation as well. So I think that's a really important part of the workup.
Yeah, and toward that end, Matt, sometimes you may have an exact idea what you want to do in a case as complicated as this. It's sometimes natural to ask for help from other colleagues, especially other surgeons, when you're looking at those anatomy pictures. But the medical issue is key. So, for example, in the ones that are clearly progressive, the ones that are very weak, the oncologists and the radiation oncologists defer to us. But in those other cases where there's time to think about it, they often will give us insights such as, do you know that this tumor may respond to this chemotherapy before you operate? Do you know this tumor there's a new drug that makes that shrink down significantly? So if it's hard for you to take out, it might be easier. And finally, if this is extremely radiation sensitive and it's a challenging case, the radiation oncologist may say this is something that they can do. So in the setting of where patients are significantly compromised neurologically or mechanically, they're going to defer to you, as is the patient, as is your natural instinct. But when there's more time to think about it, it's probably worth at least touching base with those folks and getting to know them, because they will actually make your lives easier, both for yourself and for your patients.
Yeah, and I've noticed even in my short time how things in the world of radiation have changed dramatically. So, I trained hearing chondrosarcoma is radioresistant, and chordoma is pretty radioresistant, and a lot of that, as we know, is changing. And I think I think we can try to keep up with it, but it helps a lot to have the person that thinks about that day in and day out there every week with you. So the big thing is you're working these people up. You just want to avoid, I think, making a catastrophic error, like we've been saying. So this turns out to be a lymphoma, and you plan some big en bloc resection. That's comes with it a significant risk, and that would clearly be not a great situation. Even worse would be a primary tumor in a young person who underwent decompression and had an intralesional surgery where that tumor now was opened up and contaminated the rest of the tissue. That would be a real problem, because now you've really lost your chance at a clean resection with clean margins. And there's evidence for that. There's several studies we can go through. I picked up a couple of the ones that I think show that issue the best. That is, that if you get into the tumor or do an intralesional surgery, then your outcomes are worse. And so we've seen that in retrospective data, both out of some of the big sarcoma groups shown here. So on the left, you see a study out of Hopkins. This was all comers sarcoma. I think there were only 25 patients or so in the study, looking at whether they got an intralesional surgery or an en bloc resection with clean margins, and you can see that their survival outcomes were different. Same thing applies for osteosarcoma. It's typically a little more aggressive in terms of the timing that you're following these folks, but the same thing holds. If it's an intralesional resection, then you see that they do a little bit worse in terms of survival. That's been carried out. This is, I think, 2 years ago out of the AO Knowledge Forum, looking at 166 patients with chordoma over 13 institutions, I think. And you see the same thing. Local recurrence is worse, survival is worse when you have an intralesional resection. You can look at the same thing. That was chordoma. Here's osteosarcoma. Again, multi-center recurrence and survival are worse. And so the main point here is that the margins matter. When you look at both recurrence and survival, particularly when you get a correctly powered study, I think it's fair to say that the margins matter in these cases. So what do? The first step for us in a patient that was neurologically intact and had been so for weeks was we did appropriate staging and we got a biopsy. So the biopsy came back as chordoma. And I just want to say here that I just told you that the margins matter and they're very important. And I think that's true, and I don't want that message to be lost. But I do think chordoma is a little bit complicated. And this is something we talk about a decent amount. You know, the margins of chordoma are something I think we don't totally understand right now. This is a retrospective study out of the Mass General group, out of Joe Schwab's group, looking at their, perfect timing, Dr. Schwab, perfect timing. I see that he has joined us. So basically, this is a look back over 30 years of 100 cases of sacral chordoma and trying to figure out what matters for survival and for local recurrence. Now, there's a lot to this study in terms of, they use a lot of radiation, but the reason I show it is that, it wasn't so clear that the role that margins play here. And in fact, I think 3 of these patients had an R0 resection and still had a recurrence. And so those things are hard to understand. And one of the papers that I think has started to help us figure some of that out is this paper out of Japan, where they went back and they looked at slides of 40 different chordomas, and they examined the full slide moving out from the margin and found that there were these little pockets of cells that they term microskip metastases up to 2 centimeters away. And so in some cases, you might have a clean margin, and then you might have a little microskip metastase. Now, there's a lot of questions with this, and this was all sacral chordomas. It was at one institution, so it's hard to know exactly what that means. The Mets were all in the gluteus maximus, and so again, is it a local thing? But again, I think it begs the question as to what we know and don't know about the margins of chordomas. Joe, I don't know if are you able to hear us, or can we hear you?
Yeah, I can hear you now. Can you hear me okay?
Oh, perfect.
Yeah. So I think this was a very important paper. It does, obviously it's retrospective and there's a lot of selection bias within it. On the other hand, at least in the sacral tumors where the tumor can grow along the piriformis muscle or the gluteus maximus, it does seem that it does do that, and it doesn't necessarily show up on the MRI. And so you're going to have tumor outside of the main mass seen on the MRI. Whether or not that correlates in the spine, we really don't know. I mean, it's the same histology, but the anatomy is of course different, and so we don't know if indeed the tumor is growing further outside or along muscle planes, because the muscle planes are obviously different in other parts of the spine. Having said that, there is this thought that there are micrometastases, at least in the sacrum, outside the main mass, and that to us lends some rationale for delivering radiation to these areas preoperatively, where you have some idea where they may be. Whereas, and that's one of the rationales for giving preoperative radiation. Again, that's very controversial, as this paper is, but it shows you kind of where we are in the field.
Yeah, if I can add to that point, rather than getting too down deep in the weeds in this big this overall about how to do it, I think this is extremely interesting. and Joe Schwab has been a leader in this. I think what it actually kind of does for us, it says the traditional view was for the primaries, work them up, work them up, work them up so that you get a specimen and you can get it biopsied, and maybe you have the ability to do something with negative margins, because that's what the data shows us. However, if you look at the data, they're not clearly black and white. If you get a negative margin, patients are cured, and if you get a contaminant margin, they all pass away quickly. As you see, those Kaplan-Meier curves they mirror each other a little bit. So this is kind of an understanding. And so what this means is moving forward in the field, when we all think about this, is it even more proves the point, as Dr. Schwab was saying, is that if I have a very localized tumor at the tip of the coccyx, maybe that's the easiest one to take out en bloc. But as I start having these other tumors that start to wrap around important structures, and we start thinking about sacrificing those structures to get the most negative margin possible, that we're starting to probably increase our risk to the patient, our side effects. So in light of that, we have to be thoughtful. And so the Mass General really has been a leader in this with Dr. Schwab and his team about saying, maybe we get the best of both worlds by, in some of these cases, radiating first to kill the micrometastasis, maybe sterilize the border, and then maybe take these out en bloc. And that's even evolving. In other words, that may change as we go on, as radiation gets more focused. Maybe it'll continue to be less surgical and more radiation. But at least in terms of the sake of this discussion, I just want to make sure that we understand that these still think, even though there's micrometastasis, a lot of us still want to know what these are for the ability, at least, to try to get a local control or cure.
And one question that's really for either of you is, when you see these data and we go through this, I guess the thing that bounces around in my head is trying to reconcile the view that, well, there's little micrometastases, maybe everyone should get broad radiation, or maybe there's a little micrometastases that I don't see in MR, and it would be better if I could, at some point I saw it and then I could focally target that with radiation. So post-op radiation when I see something. I don't know if there's a way to reconcile how you guys feel about that.
Yeah, these are tough. These are not, and we don't know the answer to this, is what it comes down to. And clearly there's a lot of institutional bias. We have a lot of institutional bias where we prefer to treat preoperatively, but it's bias. And there are others that would argue, you just need to have a wider en bloc resection. So, you take the entire piriform, you should take a wider cuff of tissue, in this case, a 1 centimeter negative margin in the gluteus maximus is not enough. You need to take a 3 centimeter margin. And so that's an argument towards no radiation, but a further surgical en bloc resection. Very much controversial. Our bias is to deliver preoperative radiation, but I know in other centers, they would prefer no, let's just wait and see. Maybe we're outside the tumor, and if we get a recurrence later, then we'll use the radiation, and perhaps avoid some of the morbidity associated with using radiation during the time of surgery.
Yeah, I agree, Matt. Why don't you continue to go on before we get too deep on chordoma itself and the science of the chordoma, just that we can make sure we have a big view on this.
Absolutely. So we move forward, and at this point with planning our surgery, and this was one of Dr. Shuba's cases, so I'll let him cut me off at any point. But the plan was to do a staged procedure, and we actually went back, then front, then back, and we can kind of take you through and show you how that was done with the goal of getting an en bloc resection. And so here's the view after stage 1. And so in stage 1, we went from the back, and you're looking at instrumentation from C1 down to T2. Big laminectomy here. What you're looking at is removal of the bone here, and also the vert has been tied off above and below here on the left. We did not do any balloon study before. We did do an angiogram, and I think a lot of folks have moved away from the balloon studies and have moved to doing angiograms and looking at the flow, and then having a discussion about the flow that is there, and having a discussion about the retrograde flow. In this case, it actually was, our job was made a little easier by the fact that this vertebral artery had almost all the way occluded. It had been squished down pretty good at this point, and so everyone felt pretty good that taking it wasn't going to change a whole lot, particularly after we looked at the angiogram. Yeah,
just a comment there. I think it's important that you have a lot of colleagues. We talked about radiation oncology, medical oncology, plastic surgery. If you're a neurosurgeon, having orthopedic surgeon as a colleague. If you're an orthopedic surgeon, having a neurosurgeon as a colleague. and then having vascular surgeons and interventional radiologists. So interventional radiologists, I don't remember doing this over the last 10, 15 years. I don't remember a balloon occlusion. We do a 4-vessel angiogram or 6-vessel angiogram, and really have them decide on doing different maneuvers that they can decrease the pressure. So I don't think they call it balloon occlusion, but they do have ways to check that if there's contralateral flow and good backfill. Secondly, just with regards to when Matt says do a big laminectomy here, these are, as you'll see in the pictures, these are all pre-planned cuts. So it's not just, a big piecemeal, do a laminectomy. These are cuts where we anatomically said we're going to only go to this part of the body, only this part of the pedicle on one side, cut the nerves off, all planned beforehand. And then one last thing about the axis of this going anterior. The reason I planned it 3 stages was because I did want to likely fuse to the skull. But if I fused to the skull in the first stage, then I would not be able to extend the neck, and I'd have to go through the jaw and through the mouth to get the specimen, which we do and is more morbid. So we thought about doing a posterior subaxial, or actually, I'm sorry, a C1 down to the thoracic fusion after we did our posterior cuts, then do the anterior, and then come back in the back once we had taken it out, and then hook to the skull. So that was just some of the strategy. And a lot of colleagues, when you hear these big cases like this, I like to think this, you plan, you keep thinking about it. When you think you figure it out, you stop, take a break, and then come back and plan some more, because there's a lot of ways to skin a cat or ask for opinions from other people.
I just want to comment, this is obviously a magnificent case, and is what Dan's known for, technically outstanding. And I think a very important point is, being very vocal with your patients that this is, likely going to be a 3-stage operation, and sometimes more than that. And you need to have that built in, because you really, what he was just saying in terms of not fusing to the occiput, that is a game changer in terms of what you're doing and the exposure you can get on the anterior approach. So again, that's why Dan's a leader in this field.
That's a great comment too about the laminectomy. As you can see, these are very carefully planned cuts throughout. You can see our bony cuts here, and this is our image that was taken after stage 1. You can also see that we've done a pedicle screw into 5 here, because the vert's gone, and so a lot of our risk of that was gone, and we wanted good fixation. Stage 2, we came back the next day, anterior, with this extended Lincoln Highway approach. And we came in and had to do a few things, took the external jugular, which was right there. And then we did our corpectomy of 2, 3, and 4, and took the tumor out en bloc without spilling it or contaminating, and then placed our cage. And then there in our cage, you see we actually wrapped a little alloderm around it, so an acellular dermal matrix. And then we also have a bone graft in the center of that cage. And so here you see our some imaging after stage 2. A couple things to point out that were done here that I think were really really nice. You can see some tabs have been left on this mesh cage here, and these screws into the C1 ring have gone right through. You can see them there. Those tabs to help it with some stability, and same thing at the lower level as well.
If I could just make a comment, I think again, one of the keys here, one of the key differences here, if you're going to use preoperative radiation, the complications really do go up, and I think that we would use a vascularized fibula graft in this reconstruction, principally because of the preoperative radiation. And in that case, you may even leave some muscle attached to the vascularized graft in order to protect the pharynx. And again, you don't need to do that, I don't think, if you're not using preoperative radiation. But if you're going to use preoperative radiation, it's a good thing to consider.
Yeah, I completely agree with that, Joe. And I think it not only is a great point, but it serves to underline something we've been thinking about. As a spine surgeon, I don't personally do free flaps and fibular flaps, and I don't know many orthopedic or neurosurgeons do it. So you have to then be able to have communicated this to someone who does that. And so this is not similar to calling a intraoperative consult and calling some plastic surgeon and asking them if they're a microsurgeon, ask them if they can harvest the fibula from the leg. Obviously, this takes into account the consent, the preparation for the patient, and then also planning your surgery. So it takes them a long time to find vessels and sew vessels in, and you have to be patient. You have to think about this. So once again, if this is not something that you're experienced with, or have people who can do this, or even if you do, this all has to be planned ahead of time so that it's choreographed correctly in the operative, because that may take those surgeons to get that fibula sewn in several hours, and you have to plan that in your case, and because you're the quarterback, at least for this case.
So another thing that was done in this case was the after this was placed, the rest of the odontoid was removed, and then also to really help protect the esophagus a little bit more, the sternocleidomastoid and the omohyoid were sectioned, and parts of them were taken over and placed over this hardware here, just as another border of protection. So here we are looking at post stage 2 and planning to go back in the back and get him where we would like him for stage 3. So we returned posterior for stage 3. We extended to his occiput. We spent a lot of time making sure we got him exactly where we wanted him. You can see we put in these fibula strut grafts on the left side. We were able to go to docket under C1 on the right. C2 is still there, so we had to go actually out to the skull for this one. And here you can see a couple of our cuts from that. We took, on the left side, we took the screw out of C1 actually and put some bone graft between occiput and C1. And then here you can see our final construct. And then 2 months post-op, he's been doing great. And then here he is again. We spent I don't know if Shubha wants to comment at all about the amount of time we took on his chin-brow angle and where we were putting him and where he was looking, but he was incredibly happy about where we put him, which I was worried about it, which I'm always worried about when I go to the occiput, about where I'm going to put someone and how much they're going to like it.
Yeah, I think as anytime you cross a junction, as Matt was alluding to, you have to think a little bit more. I mean, we've gone down to the point where we're looking at segmental lordosis in a T-lift, right? So if we're thinking that hard, then when you're fusing someone's skull to their neck and the amount of work that's been done relating to chin-brow angle and other occipital-cervical parameters, this is a benign tumor. This is an aggressive tumor that we may have given him long-term control of. So, when people just think quickly about putting the skull together, if they're not the skull to the neck and to the thoracic spine, you got to think about it, because this man might be living with this for years or even decades, and you want to make sure he's reasonably aligned.
Joe, I don't know if you have any more comments. The only other thing I want to say about these big chordoma cases is I think I learned from Dr. Shubha how he is incredibly clear with them in clinic about the extent of the surgery and the complication profile that could happen with every part of it. And I think that's something that I've tried to emulate, at least, is how well prepared your patients are for these big cases.
I agree. One of the things that, as I say, when patients are receiving the radiation, I have them come back and see me during the radiation frequently. We kind of have the same conversation multiple times, but it seems like it's a new conversation every time. And by the end, I think they're starting to get it, but only after the surgery do they really get it. That this is a huge operation, and it's something they can't really comprehend totally. And so the more you speak with them, and the more you open about all the things that will go wrong, because they do, the better off everybody will be.
Before we move on to the next case, the second case, Matt, there was one question by one of the participants: what's the purpose of the silastic sheath? The silastic sheath is just a plastic sheet that you see in the in the posterior approach that Dr. Goodwin showed. And that does really two things. One, which is seemingly the more obvious to a lot of people, is that when you go from the front, you're going to see the plastic before you see the spinal cord. So if you can slide it between the spinal cord and the tumor in the back and dissect that plane, then when you're going from the front and you can't obviously go through the tumor to see the spinal cord or the dura is going to be the last thing you see once you take the tumor out. So therefore it has to be released, and hopefully the sheath will show you that. A little bit more subtle, which I think is something that I've learned, is if you cannot pass the sheath from the back, if you cannot divide a plane, then you haven't done enough. So really, although the sheath definitely, when I find it from the opposite side, is always a nice finding, and I feel like I know where I am and I know where the spinal cord is. But what's even more important is that if you can get that sheath in, it's shown that you've dissected the dura away from the tumor. So when you're in the front pulling on tumor and not looking at the dura, you're actually saying, I'm good because I separate the whole thing. So whatever I'm gently pulling on is likely soft tissue in the front and nothing important in the back. So just wanted
I think that's a great point. I mean, I think you can't, every time I think I'm done or I've done so much, I want to be done with the surgery. I realize shortly thereafter that there's a lot more to do, or I wish I would have done. Putting these we sometimes use Gore-Tex in the sacral cases. It does. It really, you know you've done your dissection, and then on the next stage, when you see that Gore-Tex or cyelastic sheath, your blood pressure kind of approaches normality for a few seconds because you're so happy you see something. Oh, I've been here. And it really does help you psychologically and physically in many different ways.
I completely agree. And then one last question before the next case is there was a question on would we change our management if the patient presented acutely, and that's obviously we alluded to that earlier. So I think I wanted to be safe and have everyone who's experienced on this phone call use their own experience. But once again, if the patient has a little tingling in one leg, to me, that's not urgent. I would work up the fully and think about it. If the patient says, I got some numbness of my arm or something like that, I may also do it very slowly. But when the patient's acutely decompensating in a rapid trend, so, a week ago they were having one thing, 5 days ago they were worse, 4 days ago they were worse. I mean, this is a person who can't wait. And so in those cases, the average or the original or the normal would be just take care of it and do whatever you got to do. I think this cervical one is very challenging, but in some cases, maybe let's imagine a patient who would end up having a chordoma of T8, and it was completely in the body except coming backwards toward the canal a little bit and pushing the cord. One could argue that you do a decompressive procedure, maybe even a decompression infusion procedure, and take a very small piece of the tumor and then cover that up with something like a cyelastic sheath, and then take that back for the potential that later on that could be found to be a chordoma, chondrosarcoma, and you can maybe stage that then, and therefore you're not taking the tumor out in a million pieces, but you're taking it out in a little bit more controlled. So some people talk about in the setting of a primary tumor that's aggressive, to just take care of it like you would if it were a metastasis. But also some people say, well, if you can stabilize them and decompress them, maybe a second stage is in order, and consenting the patient for that would be nice. I'd like to hear Joe's thoughts on that.
I completely agree. And in some cases where I know I want to come back. So for instance, patient's decompensating. I got to get the tumor off the cord. I'm going to do a laminectomy. I'll stabilize above and below, but I want to contaminate as little as possible. So in some cases you have to contaminate. You've got to get some of the tumor off the cord. Okay, fine. I've done that. In those cases where in my situation, we still want to treat those patients with preoperative radiation. Most of the tumor and the cuff of the tumor, we want to give radiation. So what I'll do is I'll actually wrap the spinal cord in Gore-Tex, 360 degrees in Gore-Tex, and suture it together. So when I come back in, I can get down to the spinal cord on the Gore-Tex, and it could be a cyelastic sheath, doesn't have to be Gore-Tex. But the point is, you can come back down. You're going to come back down and operate on them, and it provides a much easier plane to dissect through and a plane away from the tumor. So I completely agree. There are times when you have to do that, but it doesn't mean you go in and necessarily just spill tumor willy-nilly. You really want to do that in as a controlled way as possible.
Great, Matt. In the next maybe 15 minutes before the hour is over, let's see if we can get through some of the high points of the second case, which is a different type of case.
Yeah, we'll move through this a little bit quickly. But so case two's changing up gears a little bit. It's a 65-year-old female comes in. She's had both medical and surgical treatment for her multiple myeloma. She's had a prior thoracic laminectomy, and then she comes in with an event where she collapsed in a parking lot. Now she has terrible back pain and left thigh pain. So like I said, she's got multiple myeloma. She was ambulating 2 days ago, and she's got known widespread disease. So here are her images. You can see that she's got collapse. I think we're at T5-6 here. Not a lot of canal compromise. And here's her CT. So she's, again, you can see the collapse. She also has a femur fracture that showed up on her imaging. And so she's probably got some sort of acute on chronic process here. Just to emphasize, I know we're moving a little bit quick, but she's had a lot of treatment. So she tells us that she's had all the radiation she's going to get, that she's had every immunotherapy, and that she has a hospice team. But she says, 2 days ago I was happy and walking around, and now she can't get out of bed. So we'll give you the questions here. You have a very similar lineup here. So palliative care, hospice only to start, restaging, stat biopsy. I don't know if Lauren, if you can get the audience response up there for them. And then you have your surgical options: decompress it, do something anteriorly, or decompress an instrument, either short construct or long construct, with or without a cage.
Yeah, I think this case in particular is a great case. The chordoma case, I think we're all interested in, and it really is technically quite interesting. But this is very, very common and a very real problem that we face with our patients and sometimes with our families. And I think it is a very, very, these are difficult questions. And I think that the choice of treatment here, and I'll be interested to see how this sorts out. But so much of this has to do with what the patient's goals are. And I think, Dan, I'd love to hear your thoughts. And Matt, so that's very interesting. So posterior decompression, looks like it's winning, but I think there is a big variety there, right? And I think that has to do with what I'm talking about. That is that it really depends on what the patient's goals are. Dan or Matt, what are your thoughts on that?
Yeah, I can't agree more. I think that some of those answers will be based, as Joe's alluding to, on the assumptions being made by the surgeon or the doctor's treating, and the assumptions being made by the patient, right? So if the patient says, well, I'd love to be really aggressive because I want to be cured, and they have a pathologic fracture of the femur and other lesions throughout their body, obviously they're going to push it toward being a very aggressive. Or if the patient says, I'm at the end of a long stage and this is too much, you're going to be a little less aggressive or more palliative. So the only other points to this one that I wanted to say is that patient had a laminectomy by another provider and had some compression on the spinal cord, and there was a CT that's not available here that showed perfect alignment, and then they had radiation, and then that patient ended up fracturing into this position, and then we got called. And so sometimes just a point being that if you are doing a decompression, even if it is myeloma and you think radiation will take care of it, be thoughtful about maybe stabilizing if you're decompressing over a thoracic spine where it may be at risk, and then you have now a potential bigger problem, or just as big a problem, because now you've got kyphosis and spinal cord compression again. So think about that.
I think that's right.
I'm sorry, Joe?
Sorry, Dan. I completely, sorry to cut you off there. I completely agree with what you're saying. And if you're going to do a laminectomy, sometimes you can do a hemilaminectomy, leave the musculature attached on one side if you're going to do something like that, because there is a real risk of them falling over. This is not a normal patient, and you have to think about the tension band. And if you can leave part of the tension band, it may help in some circumstances, because you're trying to weigh, do I want to instrument? Maybe I should do percutaneous instrumentation. But if you just open it up like a normal laminectomy, you can run into problems sometimes.
That's a great point. Thanks for mentioning that. We're running out of time, so I'm going to go through the things a little bit quickly here so we can get to the I just wanted to point out that, a lot of us start with talking about Patchell and his 2005 study showing that patients with compressive disease that get radiation and decompressive surgery did better than radiation alone. I think most people viewing this have probably looked at that study or read it, but if not, that's certainly a classic. More recently, I think a lot of us think about the NOMS framework, and that is thinking about these 4 areas for each patient. So their neurologic status, whether there's compression, oncologic status, meaning is it responsive to treatment, whether they're mechanically stable or not, and then could they tolerate a surgery systemically, and uses that to guide treatment. There's lots of algorithms out there when we talk about patients and how long they're going to live and what that means for surgery. I think this Sorg nomogram from the Skeletal Oncology Research Group is one of the better ones. I certainly interested to hear Dr. Schwab weigh in on that, as he's been actively involved in a lot of those. And then the SINS classification is something we actually use, where we talk about the stability when we see a lesion. And you can, based on these 6 categories, calculate a score where really below 10 is unlikely to need surgery, and above is probably unstable and will need something. So this patient, of course, is unstable, and we decided to move forward with instrumentation and a corpectomy at 5/6. And so I don't know if I'll go ahead and show the slides here and then let the other guys talk about it. So we did it all from the back, and we removed the tumor and removed T5 and T6 and placed our cage. And we went 3 above and 3 below. We used fenestrated screws with cement through them. I think that's something that's more and more common. Certainly we've used cement in the past for kyphoplasty for tumor patients. And I think now there's a lot of use with them in fenestrated screws. We don't typically do it, at least I didn't do them with Dr. Shuba under floor. We would actually place our screws, and then we'd get a intraoperative CT to look at our screw placement. And once we confirmed we liked it, we would then place 1.5 cc's roughly of cement in each screw. I wanted to just show this because this was as a good reminder to look at your whole CT when you get one of these intraop. And so this is our image from that case where we were checking our hardware. And as you can see, the left lung's totally been dropped here. And Dr. Shuba pointed this out immediately when it happened. And anesthesia had right main stemmed our patient, and for however many hours was just using the right lung. And so it mattered because it actually changed our plan. We decided at that point probably a little too much insult to the lung to move forward with nailing the femur, which was the plan originally. And we actually backed off and just had our ortho-onc folks exfix the femur after that. So here's the post-op uprights. You can see there. I don't know if you guys want to jump in and comment about those or add anything to what we did, or if you would have done it differently, Dr. Schwab.
No, I think one of the things to remember about these surgeries is that you've got a patient who does have limited life expectancy, right? So you're trying to you want to get them moving right away. You don't want to have a construct that well, I'm going to put you in a brace and we're not going to have you ambulate. You know what I mean? We're going to restrict your activity. You know, the idea is this patient is dying. You want to give them as strong a construct as possible so you can get up moving right away. And this is a very strong construct. And so, I mean, I think this is the right thing to do. You don't want to leave the OR thinking, gee, I hope this person doesn't live very long because that reconstruction is not going to make it, if you know what I mean. And this is not one of those examples.
Yeah, and I think just to add on to that, my consents both seem to get longer and shorter as I get older. The longer in the sense that, shorter in the sense that I seem to be able to decide exactly what I want to do and tell patients very specifically. But then to Joe's point, it may be a staged case. You may say, we are going to do this, and my hope is that we're going to put screws in. If you're not doing that, great. We're going to do a decompression alone, get out of there. And what I want to make sure that the people who are listening tonight, they say, hey, this person's just really weak. I'm just going to go in there, do a lammy. It's the middle of the night, and just do a lammy, get that tumor out, get them walking, and maybe not in this case, but in another case, and then that's it. And the argument may be, we're going to do this, and the consent may be potential stage because the patient actually does really well and mobilizes and moves their legs the next day. And you say, you know what, I'm not happy about having done that, and I want to do some perk screws, or I want to do something else, or some kind of minor other adjustment. So don't feel like sometimes we'll see, to Joe's point, you do the smallest one possible just to get out of there. On the other hand, also understand the balance is that you don't want to do it too much and then have the patient, like Dr. Goodwin was saying, we saw that CT and they'd main stemmed they put the ET tube in the one side of the lung, only one lung. And so we decided at that point not to do a leg operation, if you will, or hip operation as well.
So I think we're kind of running short on time here. Well, I'll give you my conclusions and see if the other guys want to add anything else. I mean, I think to wrap up, I think it's important to remember metastatic lesions often require stabilization, as we've been talking about. Cement can be quite useful here. And we have lots of tools now. We have SINS, we have the SORG. I think others are going to continue to inform us as we move forward, and we'll only get better in that regard, I think. I think obviously for primary tumors, en bloc when possible. And, when it's an unknown lesion, the biopsy is going to have to drive the care. And when you get in the position of when you're going to go to the OR, because there's a progressive paralysis, like we've talked about already. I think that's difficult. Dr. Shuba used to say when I was a fellow, we're going to be thoughtful, we're going to do the right thing, and I think that's true. I think every case is going to be individual, and I think as long as you kind of understand the principles, you try to do the right thing.
Yeah, I would agree with you. I think that's one of the interesting things about spine oncology. Every case should be individualized and can be individualized. That's one of the things that makes it interesting. If you're not really thinking and you're kind of getting into a routine, as it were, you're probably not thinking it through clearly enough, because these cases really do require you to think differently on each one.
No, I absolutely agree. And right now, I think that we've covered a bunch of things, and I want to thank Dr. Schwab and Dr. Goodwin. We had a number of comments. If questions come up beyond this, we obviously are SRS members and would love to be involved either personally or through SRS in terms of more learning or more comments. When you have time to think about cases, as I know I do, and I'm sure my colleagues get as well, I get a text or a phone call at least once a week on some very complicated case. And I think that's a good thing that we have colleagues and that the SRS can help us to be a kind of a group, a fraternity and sorority, whatever, a group of people that can be together and really share learning. So don't feel like you're on an island. This is one way to do it, but beyond this, phone calls, emails, pictures when you have time. If you don't have time and the patient's declining, you do what you got to do as the best doctor you can, but then rethink about it and come back to it and say, what could we do differently? And then we're all working on research. So I think I want to thank my two colleagues here, Dr. Goodwin and Dr. Schwab. I want to thank Lauren and the Scoliosis Research Society, and Dr. Sponsell, I know is on this call as the leader of this group. Thank you for attending, and it means a lot to us. And I wanted to let Lauren have the last word with regards to following up after this. Lauren?
Awesome. Thanks. Thank you to our panelists and everyone for attending tonight. I just wanted to let you all know you can send any other questions to info@srs.org, and those will get forwarded on to our panelists. Otherwise, look out for a follow-up email later this week about claiming your CME and watching the recording or sharing it with your colleagues. Everyone have a good night.
Outstanding. Thank you.
Good night. Thank you, everybody.
Thank you.